be talking about lumbar discs, mostly focusing on the operative aspect of it since we have other speakers dealing with the pain generators and the injection techniques. So this is a very beautiful picture which I got online. That's Hexensius, which was a German witch many years ago, where they thought that the lancinating pain occurring in that individual's leg is actually because of the arrow that she's pointing at. So this is just to point out that lumbar radiculopathy or radicular pain secondary to herniations was discovered very long ago. As surgeons, our understanding of this pathophysiology, natural history and treatment of discs has continued to grow more sophisticated over the years. By 1932, the first operation was carried out with a ruptured intervertebral disc by Mixter, a neurosurgeon, and Barr, an orthopedic surgeon. At that time, an L2 to S1 laminectomy was performed on a 28-year-old who exhibited the classic sign of nerve root compression, limited motion at the LS junction, positive SLR on the affected side, and an absent ankle reflex. A 1 centimeter mass was removed and the patient recovered from surgery with complete resolution of his radicular symptoms. Back then, these lesions were called enchondromas and not discs. That came out to be later when in 1940, when they realized that, that's a disc. So the point I want to highlight here is that lumbar traction gained a lot of popularity for managing these herniations. Some even postulated that the herniations actually go back into the space in the 1970s. I think it stood the test of time, but until 2013, where there was a Cochrane review where they clearly mentioned that for people with low back pain and sciatica, whether the pain is acute, subacute or chronic, there was low to moderate quality evidence that traction probably has no impact on pain intensity, functional status and global improvement. Regardless, these modalities still enjoy broad use. So I think all of us are aware from that day there's a mixed consensus as to whether to give traction or not to give traction, knowing that the results are same. So again, in the late 90s, early 90s maybe, these were the things that had taken up the market, where more and more discectomies were performed. The second procedure was the hemilaminectomy, the diagram, and the third was a complete laminectomy. So they literally stood the test of times because these surgeries were open surgeries. They had more dissection, more tissue damage, more loss, and patients over time have come back with chronic back pain. So now, what are the new techniques? We have the lumbar microdiscectomy, which was started in the late 90s, early 2000s. They went ahead and had a muscle sparing approach, which was initially actually described by Wiltse, but then it gained popularity knowing the kind of periosteal stripping and the soft tissue dissection you had. They didn't want to do that. Then there was the transforaminal route, which was given by our own Cambin. He had his study of 100 patients. There's this tubular retractor technology, and there's endoscopic techniques. So lumbar microdiscectomy was something which was which was followed before the use of microscope. I think a lot of people had dissected. The use of the macular retractor was very rampant, but it was still an open procedure. Now with the advancement of microscopes, we moved ahead and we had microdiscectomy. I'm sorry. So coming back to the other option, this was the muscle sparing approach developed by Wiltse, where they kind of made a longitudinal incision over the sacrospinalis between the multifidus and the longissimus. Now this approach was essentially developed or maybe mastered to tackle foraminal and extraforaminal herniations. And Wiltse in his time showed very good results with this approach. This is how the bone model looks like, where the one to your left is the classical laminotomy approach, where you've done some partial fascectomy, and the one pointed at the extreme right with an arrow is the classical decompression achieved by the Wiltse approach. Dr. Pervin Cambin was the one who thought of this route called the transforaminal route, where he identified a safe zone called the Cambin's triangle, named after him, where the exiting spine root and the traversing spine root, there's a window. That window can always be addressed, and herniations essentially which are foraminal and extraforaminal can be tackled by this approach. He essentially had developed this knowing that here the incision is not in the midline but approximately 8 to 9 centimeters away from the midline. So this approach had gained popularity, and he concluded that complications such as post-op bleeding, perineural scar formation, which was very common with posterior approaches, and reherniation that are often associated are avoided through this approach. He continued to treat lumbar disc pathology through the transforaminal corridor, and later published his results regarding 100 patients with 87% success rate. So the tubular retractor technology, early 2000s, we had this where now we started using the tubular retractors, further narrowing down our incision and avoiding soft tissue dissection, muscle dissection, and providing the same vision. But this, the surgeon was always relying on a microscope or an operative loop to carry out his dissection, with better instruments in the form of the instruments had to be bayoneted. Coming to endoscopy, these are the three routes that we know of: the extraforaminal, the interlaminar, and the transforaminal. Now, endoscopy is something which has gained a lot of attention over the years, maybe around 2015, when a lot of surgeons from the Korean group started rampantly operating on patients with this approach. These techniques have two windows. One is the interlaminar window, which can be achieved by a unilateral biportal endoscopy, or one is just a percutaneous endoscopic lumbar discectomy. Over here I can show, you can see that a unilateral biportal endoscopy requires two portals, whereas a classical lumbar discectomy requires one with still a soft tissue dissection with the same level posterolateral herniations being addressed, but with less soft tissue dissection and bleeding again. Now, this is how you do it, where you have the medial border of the pedicle, you mark it, you dock your tube, or you dock your portal at the spinolaminar junction, and this is how you address it. In a similar way, you have the same technique going interlaminar with a PELD, which is a straight vertical endoscopic portal, which is the percutaneous endoscopic lumbar discectomy, both having very minimal incision, having the same optimum outcome, but the caveat here is that it requires a longer learning curve, maybe even more longer than those minimally invasive techniques that we have developed over time. So this is a diagram which I wanted to show you all for those herniations where there are cranial migrations and caudal migrations. Now, as surgeons, we know that this is the place where we actually struggle intraoperatively, when you know that you're doing a laminectomy or a laminotomy, and then you have to either extend it or go either ways. But with the advent of this endoscopic techniques, you have these new instruments which kind of, bend intraoperatively under the vision, where you can actually insinuate them proximally or distally depending on your approach, and you can remove these herniations. So you can achieve the same thing without an extensive bone resection and without much struggle. This is again a nice diagram of transforaminal endoscopic discectomy, where you again take the same approach, but in a minimally invasive way. Your incision is far lateral, around 8 to 9 centimeters from the midline. So this is the in-out technique, where you are not addressing a herniation which is actually there. You first go inside the disc, remove certain part of the disc so that the herniated part kind of falls behind. So you are banking on an indirect decompression, but there is an out-in technique as well. And one more point I wanted to highlight in the diagram to your right was, a lot of times you've seen, these pathologies are no longer singular. In adults, you have concomitant pathologies where the disc is herniated. Along with that, you have some hypertrophy and early foraminal stenosis. So this technique, when you kind of get the endoscope out, you can still visualize the hypertrophied superior articular process, and just doing a foraminoplasty or just resecting that tip, that extra articular part of the superior articular process, you can achieve the same result by clearing the foramen. This is yet again a nice pictorial depiction of how the herniation is distal, but with the endoscopic technique, you can still reach there without resecting much of the bone and achieving the same result. So to conclude, the evolution of managing lumbar disc herniations has evolved over the years. clinico-radiological correlation has played a major role in managing these herniations with more precision. And open procedures have stood the test of time and are only reserved for selective cases. However, use of microscope and endoscope with better instruments have made disc herniations easily accessible via various routes without compromising on the operative outcome. Thank you.